good morning, everyone. I'd just like to share something that I learned from this patient, Mr. S, who was a 33-year-old unemployed gentleman from Valaja, who presented with complaints of one episode of a generalized tonic-clonic seizure at 5:30 a.m. of 6th of Jan. Following the seizure, he also had complaints of generalized weakness for the next 5 days. There were no previous episodes of such seizures occurring. He was a known case of, he was labeled as intellectual disability and psychosis, and he was under follow-up for that in MHC Bagayam. And his regular medications included risperidone, chlorpromazine, and flufenazine, but he'd been off the medications for the last 1 week. There were no known comorbidities in him. He used to smoke 24 cigarettes per day for the last 20 years. Examination in the emergency department, when he had presented, his pulse rate was 94. His blood pressure was 170, and he was dehydrated. The rest of the systemic examination was not remarkable, but I would like to note that he had reflexes that were intact, and his muscle power was intact, 5/5, in spite of the electrolyte abnormality that we'll see following this. So we have the initial investigations showed a hyponatremia, a severe hypokalemia, and increased bicarb, suggestive of an alkalosis. His liver function showed a mild transaminitis, and his renal functions were normal. CT brain showed a calcified granuloma in the right parietal and temporal cortex. And ECG showed prolonged PR interval, widespread ST depression, and a QT prolongation, which is probably secondary to the hypokalemia that he had. The urine routine and the ultrasound abdomen were unremarkable. The initial VBG showed a pH of 7.63, a severe metabolic alkalosis with a bicarb of 55.8. And he also had concurrent hypomagnesemia and hypocalcemia. So we have a gentleman with seizures, and we have a structural cause for the probable structural cause for the seizure, and multiple electrolyte abnormalities that would explain the seizure. So just summarizing this gentleman, it's a 33-year-old male patient who presented with hypokalemia and hypomagnesemia with metabolic.
Recording in progress.
So, in conclusion, I have a 33-year-old male patient with hypokalemic, hypomagnesemic metabolic alkalosis with normotension. Now, the differentials or the approach for that is what I would like to go through. This is what Harrison's gives as the approach. So, in a patient with hypokalemia, first, I would like to rule out pseudohypokalemia, which occurs when you have thrombocytosis or leukocytosis, where there are a lot of cells which uptake the sodium, which uptake the potassium, which he did not have. His counts were normal. There was no history of it's very unlikely that the sample was also kept out for a prolonged period of time, which could cause pseudohypokalemia. There was history of low intake in him. But low intake alone would not contribute to a hypokalemia that is so severe. There was no evidence of a transcellular shift as a cause for his hypokalemia, such as insulin excess, beta-2 adrenergic agonists, hypothyroidism, barium intoxication, theophylline, or chloroquine. So then what we would like to know is what the urine potassium was, whether the kidney was conserving the potassium or whether there was renal loss in spite of such a severe amount of hypokalemia. What Harrison had recommended was a 24-hour urine potassium, which is not possible because he was acutely sick, or a potassium creat ratio, which is not available in our biochemistry lab. So then what we have is a urine spot potassium, which was elevated, suggesting that there was renal loss in spite of this severe hypokalemia. Then the next step would be to calculate the TTKG, the transtubular potassium gradient. and in him it came to around 21, which is more than 4, signifying that it's not due to increased tubular flow such as osmotic diuresis, but it's due to a potassium secretion that is happening in the tubules. So now this is now from here, the next approach that we would want to do is to look at him clinically and say whether look at his blood pressure and his volume status. So we know that he was dehydrated and he was normotensive. So clinical assessment will actually branch us out into different differentials as in the next process. So since he was a normotensive gentleman with dehydration and he had metabolic alkalosis, our differentials were very limited. And the one investigation that we have to differentiate further was the urine chloride in him. And the urine chloride in him, the urine chloride would tell us, if the urine chloride was less, it would tell us that the body is trying to conserve the chloride due to some loss, such as vomiting or such as a chloride rich diarrhea. But if the urine chloride was elevated, that would tell us that there was some renal tubular dysfunction that was losing the chloride. So we did a urine spot chloride in him that came as 111. It should have been, it's definitely more than 20. And that would now really narrow the differential to just two things, either diuretic abuse or diuretic use, or a inherited tubulopathy such as Bartter's or Gittelmann's. So in him, the other thing that the next step that would help us differentiate further would be a urine calcium chloride ratio, because in a loop diuretic or in Bartter's, you would have calcium loss in the urine. You would have hypercalciuria, which is also one of the reasons why you would see nephrocalcinosis in patients who have Bartter's. So we did a urine calcium chloride ratio, calcium creatinine ratio, and the calcium creatinine ratio came out to be 0.67, which finally brought us down to the end of the algorithm at either a loop diuretic or a Bartter's syndrome. We took a very thorough history, and after repeated confirmation that there's no possibility that he could be taking a loop diuretic, the only other potential diagnosis was a Bartter's syndrome. Now, going back to the history, when we went back to the history, we found out that he was born to second degree consanguineous parents. His mother reports history of polyhydramnios at birth, and there is history of polyuria and polydipsia. So he consumes, they give him a quadum of water to drink, which is around 7 to 8 liters a day. And he also has a family history of an elder sister with a history of intellectual disability and sensory neural deafness. So these with all of this put together, the diagnosis seemed like Bartter's syndrome. Bartter's syndrome was first described by Bartter in 1962 in 2 children with hypokalemic alkalosis who were normotensive in spite of having hyperaldosteronism. And the clinical features of Bartter's syndrome are: antenatally, they would have polyhydramnios or preterm labor; postnatally, polyuria, polydipsia, salt craving, failure to thrive, growth retardation, dehydration, low BP, and the muscle weakness and seizures. So he had a few of these clinical features present in him. Subtypes of Bartter's, I just want you to know that there are 5 subtypes. We won't go into the genetics of it, but just something about the pathophysiology of Bartter's. The basic defect in Bartter's is that the sodium chloride NK2Cl channel is not working. So the kidneys cannot absorb sodium and chloride in the thick ascending loop of Henle. Now, because of that, what happens is all the sodium and chloride goes even more distally. So there's increased distal delivery of salt and water, which results in salt and water wasting. So there's hypovolemia, and because of that, there's secondary renin-angiotensin-aldosterone system activation and causes hyperaldosteronism. When you have excessive distal delivery of sodium, because of what we saw just earlier, the sodium gets exchanged with potassium and H+. So sodium gets reabsorbed, potassium and H+ gets secreted. So that explains the hypokalemia and alkalosis that is seen in Bartter's. There's one other point that I want to mention, which is the impaired entry of sodium and chloride in the macula densa in Bartter's increases the expression of COX-2, which increases the renal production of prostaglandin, and that causes afferent arteriolar dilatation and renin secretion. The reason why this is important is because the therapy for Bartter's is actually targeting this pathophysiological phenomenon. Our gentleman presented in our patient presented in adulthood. So the most common Bartter's that we see in adulthood is actually type 3. And there is a very close differential for Bartter's, which is Gentleman's. We saw that in the algorithm we saw earlier. And the main differentiating feature is actually the urinary calcium. And Bartter's would have a normal or high urinary calcium, while Gentleman's would be low or normal. I just want to bring to your attention that there are certain acquired causes of Bartter. So it need not always be inherited tubulopathy. Specifically in aminoglycoside poisoning, you would have aminoglycoside toxicity, you would have an acquired Bartter's. So aminoglycosides are known to cause a tubular dysfunction. So if you can either have a proximal tubular dysfunction, which presents like a Fanconi's, glycosuria, phosphaturia, aminoaciduria, or you could have a distal tubular dysfunction, which presents like a Bartter's, which is what which is hypomagnesemia, hypocalcemia, and metabolic alkalosis. Then there are case reports of TB, Sjogren's, and sarcoid also causing an acquired Bartter's. So the management of Bartter's would be supplementing the electrolyte deficiency. So salt supplementation, potassium supplementation. It's important to note that you would supplement it with a chloride salt of potassium, because if you give potassium citrate, that could cause a worsening of the alkalosis, because citrate through the alanine cycle would get converted to bicarb. Then NSAIDs, selective COX-2 inhibitors such as indomethacin, is used because it targets that specific prostaglandin excess that we talked about in the pathophysiology. You could also use potassium-sparing diuretics such as spironolactone. The course in the ward of our patient, he developed 3 further episodes of seizures. He was loaded and started on levetiracetam and phenytoin. There were no further seizure episodes. He also developed, we noticed that he had dark colored urine in his urine bag, and his CPK was elevated, so to 19,448, which could be secondary to the hypokalemia itself or because of the multiple episodes of seizures. He also had a septic shock secondary to an aspiration pneumonia, required NORAD and oxygen. He is on meropenem, but currently he's doing well. He's off inotropes and oxygen. All his electrolyte abnormalities have been corrected, and we are planning to discharge it. So take-home points. The first thing that we saw was an approach to hypokalemia. And secondly, in a patient with unexplained hypokalemic metabolic alkalosis with normal or low blood pressure, we would not think of Bartter's first. We should actually rule out much more commoner causes such as diuretic use, laxative abuse, surreptitious vomiting. So a very careful history and examination is important for that. Some clues would be if very, very common is people who induce vomiting in themselves, they'd have scarred dorsum of the hand, they'd have an impaired gag reflex, they'd have parotid gland hypertrophy. So good examination and a very careful history should exclude those causes, and then we would think of inherited tubulopathies. And the last learning point would be to remember acquired causes of Bartter's, such as prominently aminoglycosides. Thank you.
Thank you, John Roy. I think that's a very extensive and systematic approach to hypokalemia. I just have one question. Do you think your patient had an acquired cause of Bartter's?
They're very unlikely that he had an acquired cause, sir. At least in the causes that I had read of.